now we start with him, Alexej Barg, Vice President of the International Weight-Bearing CT Society, weight-bearing CT in patients with syndesmosis instability.
So ladies and gentlemen, dear colleagues, first of all, I would like to thank you all for coming that early morning. Feel free to have a copy, not to fall asleep, and I will try to do my best to show you some interesting stuff. I'm speaking about the weight-bearing CT in syndesmosis instability, and my special thanks goes to my co-workers. This is especially Dr. Kranbil, who was actually a research fellow for a year at the University of Utah, and this was his major project. Then, of course, my chairman, Dr. Salzman, who is very interested to move forward with the research. Then Dr. Burssens, who actually joined the University of Utah right after Dr. Kranbil left, and he was also involved in this project. And at last but not least, Maxwell Weinberg, who is a part of my research team. He is a research assistant. So I don't want to waste too much of your time to speak about the general remarks about the syndesmotic injuries, but we all know they are common, and some of them, do we really need weight-bearing CT? I don't think so. If you cannot see the syndesmotic injury on the left picture, then I don't think you should be an orthopedic surgeon. The problematic is if the patients come with different types of symptoms, and you should keep in mind that syndesmotic injury occurs quite often as a concomitant injury. And this is something for me, I was a bit surprised that about almost a fourth of all ankle fractures comes together with syndesmotic injury, more or less. And very important, about 80% of all ankle sprains have also a significant syndesmotic injury. And honestly, not everybody who sprains his ankle goes immediately to the doctor. The problem is quite often I see those patients in my clinic and we can tell this is already too late. The problem is if you're not recognizing the syndesmotic injury in time, then you may have a quite devastating outcome. So you may have an end-stage arthritis, and like in these patients, the only reliable options I was able to offer was the fusion. So when we take a look how we can image this syndesmotic injury, Dr. Kranbil put it together, the systematic literature review, and we can say is right now there is three big columns, how to use the imaging to diagnose the syndesmotic injury. This is for sure the conventional radiographs, and if you take a look on the conventional radiographs, you can see this is always a two-dimensional imaging right now here. And we try kind of to see there is some clear space or there's some overlap. Those are the two major principles if you try to image them. And again, you can do them weight-bearing. Sometimes if it is early postoperative course, you cannot do them weight-bearing. But again, those are the two-dimensional imaging. Then you can see, okay, if you're not sure what you see on X-rays, let's go for CT, for computed tomography. But also here, this is a two-dimensional imaging, and honestly, when you see the big fracture, then you can see that clearly on CT scan. However, when it's the subtle instability, then you may miss the weight-bearing to see certain differences. And the MRI is usually concentrating just on direct visualization of the stabilizing structures. So to summarize, we can say, okay, MRI can tell you that it has a sensitivity and specificity of nearly 100%, and you can say, okay, there is a damage of the ligament, but does this little damage possible have outcome or influence on stability of the hindfoot? You can't really take just based on the MRI. Another problem is the majority of the imaging I show, they are non-weight-bearing condition, especially the conventional computed tomography, especially the MRI, which means that certain instability outcome, you may actually underestimate them. Another problem is also here you still take a three-dimensional imaging, which is CT scan, which is MRI, and you transfer them to the two-dimensional imaging, so you may get a substantial loss of information. And actually, Dr. Burssens, he thought about this, and he was actually starting to use the weight-bearing CT in the patients with the acute injury. And I don't want to go deep too much in detail into this method. He will probably mention this today later. However, the templating methods means that you take a healthy ankle and you take the injury ankle and you overlap it on each other, and then you can clearly see even the smallest differences. And in this publication, he was able to show that the templating method is an effective method for quantifying of syndesmotic injuries. It is, however, still not clear whether the weight bearing is that important when we do apply, when we do assess the syndesmosis. And this is one of the paper where the Cesar Netto was involved. And this is a prospective study with 27 patients with syndesmosis injury. And also here, the bilateral weight-bearing CT was done. And for this particular study, only uninjured side was analyzed. And weight-bearing versus non-weight-bearing conditions were assessed. And as I saw this paper, I was hoping to see much more statistical significance at the end. However, Cesar demonstrated that only MCS is the only one measurement which shows the statistically significant difference. So maybe we can say, okay, why we should use weight-bearing CT? Because the study from Cesar show there is almost no difference. It's just one measurement out of, I think, more than 20 you performed in this study show it. We weren't sure, and maybe the weight-bearing is not the only one thing. So what we did, we used a cadaver study. We used the 14 paired male cadavers. We created this custom-made radiolucent frame. And then we built up two groups. The one group was AITFL group, one group was the deltoid. And what we did, we wanted just to partially dissect the syndesmosis. We did not want to dissect it completely, which means this is sometimes you can see possible in patients with the subtle syndesmotic instability, which is really hard to diagnose. We did several measurements. We did the digitally reconstructed radiographs. This is how usually the doctors use it to diagnose the instability. And then what we did, we wanted to analyze the impact of the weight. We had the three different conditions: full weight bearing, half weight bearing, and then also non-weight bearing. And actually, in DRS, we were able to confirm the results from a Cesar study, so there was no difference between ATFL versus deltoid ligament transections, and also weight bearing, no significant impact. Then we also used the typical CT scan, and also here we were hoping, okay, now we're going from DRRs, from conventional radiographs to the more detailed imaging. Maybe there we will see any difference of weight bearing. Not at all. But then we were thinking maybe it's not just the weight bearing which is important. And then we tried to apply some torque. So we used the 10 Newton meter of external torque, and this is actually the physiological torque. There is a several study demonstrating that the patients can apply this torque without having too much pain. And then right there, we were able to see, okay, the torque is the key. And then out of sudden, several measurements were not statistically significant with or without weight bearing. When you add the torque to them, then you see the big difference. And we were able to show that the torque actually improves the accuracy of pretty much all measurements we used in this study. The problem is the deltoid injury still remains a mysterium, so we were able to detect the subtle syndesmotic instability, but we were not able to detect the deltoid injury. So in conclusion, we can say, you will hear many times today, that the weight-bearing CT is an emerging modality. So many doctors use it, and I think we are heading in the right direction. There are several advantages, and to summarize some of them is a natural standing position, high contrast, spatial resolution, and very important, because the patients applied the weight, you can see the alignment, and you can see actually whether the degeneration you see is clinically important. Clinical use so far, at least in my clinic, is when I want to fuse the patient, I want to replace the patient, or I want to do the realignment. So every time we work around the bones, we use the weight-bearing CT. However, in the last time, I try also to use this new technology also in the patients with a hindfoot instability, as I mentioned in the study. And we just recently started to do a clinical study based on the findings from this cadaver study. We are working on it, and hopefully next year when we're standing there, we can present those results. Thank you very much for your attention.
Thank you very much for this great talk. As mentioned before, we will have the discussion at the end, so we will move on with the second talk, weight-bearing CT for assessment of metatarsal rotation. Dr. Wagner from Chile, please.
Okay, thank you very much for the invitation. This is my first time in this meeting, although I've been having the need and to assist, and it just was not possible, so I'm very happy to be here to share this with you. This was originally my brother's work, and we have been working together with this idea of the metatarsal rotation. And as an introduction, as Alexej was saying, why is it important to measure rotation? We like this example of seeing the prince showing his middle finger, which if you look at it from the front, really he's showing 3 fingers. So this is just a nice example, a funny example of how we have to take in consideration every point of view, and this is especially true for our identification of multiplanar deformities. And you know, for many years we have been correcting only the varus deformity in hallux valgus, and maybe this is again as an introduction. This is why I left this question here. Have you wondered why the metatarsal head looks round in many patients? So this is a normal one, and this is an hallux valgus case. And when I did my fellowship 15 years ago, I was told that it was also always the DMAA, the distal metatarsal articular angle, which was changing. So these are all examples of hallux valgus patients, and if you see, you can draw a line which is not a perfect square line in every case. So this is really metatarsal pronation. So if you see at this metatarsal, this is a cadaveric model. If you hold it perfectly straight in front of you, you can find an angle there in between the articular joint line and the lateral aspect of the head. Whenever you rotate it, part of the metatarsal condyle gets into the view, and then the line becomes rounded in between the joint line and the metatarsal condyle. So for us, every time we see a rounded head, we think in pronation. And these are these same examples to show to you how it makes, rotation makes more a metatarsal rounded head. So this was demonstrated some years ago by even Charlie Salzman, that 87% of hallux valgus have pronation. And it's important because it has been shown, and there are some late articles in the last 2 years, in which just the pronation, this deformity has been linked to worse clinical outcomes and a higher deformity relapse rate. And this is one of my cases in which I did a scarf, and I was so happy because I thought I corrected a lot of varus, and I did. I did correct about 10 degrees of varus, but the metatarsal head remains in a very nice rotated position. So this is a good correction of the varus, but a horrible correction of the rotation. And this is an example of one of our cases in which we're doing a proximal osteotomy to correct both the varus and the rotation. And you really can see in the OR and after the operation how you do correct the shape and the rotation of the metatarsal head. So the classic ways of measuring rotation are the weight-bearing axial sesamoid view, which is very difficult to take. With my brother, we were trying along 3 years to have our X-ray technicians to improve it, and it's not possible. I think it's just not humanly possible. So what we have been using is the AP foot weight bearing, and I think the weight bearing CT scan is what we need to make it popular and to use it all the time. So if you see at this metatarsal head, the joint line is not square. You find a step and then you find the metatarsal condyle. So this metatarsal bone is just starting to rotate. So we've been following these cases, and we have a study in which we compare CT scan against an AP view. And for us, this is a low level of rotation, and it is equivalent to a rotation of 10 to 20 degrees. And I'm going to show you the equivalency with a weight-bearing CT scan right now. A level 2, it's normally when you see a rounded head, but you can see a notch, a small step. It's not a step, a gap you can measure, but it's like a notch. It's a change in the curvature of the metatarsal head. And if you see, excuse me, a completely rounded head, that's already more than 30 degrees of pronation. You can almost fit a circle around it. And this is not an invention. Yamaguchi, some years ago, in studying this issue of rotation, these are cadaveric models, and this is the lateral side of the metatarsal bone, and he was increasing rotation, and you can see that from 0 to 30 degrees, the lateral aspect of the head is more round and more round. So regarding weight-bearing CTs, you search on the literature, there's not much published about it and how to measure it. This is one of the only late studies about 2 years ago by Kim, if I remember well. But he used this method, drawing a dorsal representation of the dorsal cortex of the metatarsal bone and a plantar one, and then drawing an angle against the floor and calling this an alpha angle. The problem with this is that it can measure rotation, but it also will take into account the varus. The varus will change this alpha angle. But at least he showed that he was using a reference line in between one facet and the other one. So what we propose is perform coronal cuts and choose the cut in which hopefully we are following correctly the axis of the metatarsal, and find the cut which includes the best view of the medial metatarsal-sesamoid facet and the lateral metatarsal-sesamoid facet, and draw a line along that imaginary plane, and then take the floor and use that as the metatarsal rotation. And we're performing this study in which we're trying to make an equivalency between this, which is an AP view of the metatarsal head, which for us has a low level of pronation, and we don't have the CT scan in. We do have it in Chile. It's not operative. It will be operative. These are images from some friends we have in Baltimore. So they did some measurements of this same case, and that head has a level 1 pronation, which is 18 degrees. Let me show you an example of 23 degrees of rotation. So that head, take a look at this. It's not completely round. You can see that there's a change in curvature. So for us, it should measure between 20 and 30 degrees. And as I told you, it measures 23 degrees on the CT scan. And finally, a level 3 deformity in which the CT scan measures 31 degrees. You see that this is almost a perfectly rounded head. And this is the equivalent CT scan in which we measured 31 degrees. So this presentation wants to try to introduce this concept, if you don't have it already in your mind, that pronation has to be assessed because we think we can correct it, we think it's important to correct it, and as you may know, we have a way of correcting it. It's an osteotomy. It's came with the help of a company here, and I think weight-bearing CT scan is something very helpful, but I think we need to get a consensus in how to measure metatarsal rotation. Thank you very much.
Thanks, Dr. Richter and Dr. Barg, to invite me to give the talk. So we're going to talk about the flat foot. I do have some disclosures, and would like to start with the regular X-ray. So we have the views of a flat foot deformity here, and let's say that this patient got to your clinic, and of course he had some symptoms, or she or he, but it's not that bad. Also, there's some symptoms, there's some pain. The foot is probably collapsing more and more, but it's very difficult for us to decide when to pull the trigger. So when should you be aggressive and offer surgical treatment for a patient that is symptomatic, but still can live with the deformity, or still can work properly with the deformity? So wouldn't it be good if we were that organized the same way the clinicians are, and they have right numbers for everything? So just showing here for diabetes and for blood pressure, high blood pressure. So they have pretty good numbers, and they follow that pretty strictly. They will offer you treatment if you are above the numbers that, or the thresholds for both the pathologies. So this is what is driving me in flat foot. So I've been trying to play with the numbers, and I hope that until I'm done with my career, I can bring some precise information of when should we treat the patients. So playing with the numbers, the magic numbers, would be really cool. So I'll show quickly 2 studies that we have been doing. We are far from getting to the numbers, but we are trying to walk towards that direction. So we did, this is not published yet, it's submitted but not published. So we did compare findings of CT scan and MRI, and we are gonna go back to the same patient that we see the deformity here, and then a really bad name for flat foot deformity, that is posterior tibial tendon dysfunction. That's already in the literature, it's not something new. But this patient, if you look to the MRI, he had a posterior tibial tendon that was pretty preserved. There's a little bit of insertional pathology, but it's a pretty good tendon. And when you look to the ligaments, the spring, the interosseous, you can see there's a lot of degeneration, and you can see in the MRI, even though it's non-weight bearing, you can see sinus tarsi impingement. When you look to the CT scan, then you go to the third dimension that the X-ray does not provide you, that is the coronal view, and you can see here subluxation of the subtalar joint. You can see sinus tarsi impingement in both coronal and lateral planes, and we are not even talking about looking at this in the real three-dimensional images. And so how do we differentiate these 2 degrees of deformity? So sinus tarsi impingement, degree of subtalar joint subluxation, and subfibular impingement. I really believe that these 3 things can be part of the equation and should help us to define when to treat those patients. So we included 55 patients. We did 4 blinded readers for the CT scan and the MRIs. And we found that from the patients, 71% had sinus tarsi impingement. That should be a more a low-grade injury. 70% had subtalar subluxation. That is parallel to the sinus tarsi impingement. And the subfibular impingement is probably more severe, just 9% of our patients. And if we look to the degeneration of the soft tissue structures, we found much more degeneration of the spring and the interosseous when compared to the posterior tibial tendon, and that was already in the literature, but we found similar results. And when we look to which soft tissue degeneration would influence the presence of the sinus tarsi, subtalar joint subluxation, and subfibular impingement, and ironically, we found that for the sinus tarsi impingement, the only variable that correlated significantly or the influence significantly was the posterior tibial tendon dysfunction. But for the subtalar joint subluxation and the subfibular impingement, the interosseous and the spring ligament were the only ones to correlate. So the degeneration of those 2 structures are probably related to the more severe deformity. And looking to the image, that's something that's also submitted. I hope it will be published soon. But then we started looking, so the literature, the term paratalar subluxation for flat foot deformity was popularized by Dr. Hansen. It just tried to comprise the whole deformity. And there's a pretty good study by Dr. St. George's group in Seattle that first evaluated that posterior facet and a combination of the anterior and medial facet. And they demonstrated in a very cool way, they were able to superimpose the facets, and they showed that the flat foot patients would have significant decrease in the overlap of the facets, and that was much more important in the anterior and medial facet than in the subtalar facet, the posterior facet, I'm sorry. But this was left in the literature. Nobody ever talked about the medial facet or the anterior facet anymore. It was all focused on posterior facet, including my studies. But looking to the images, I started to notice that the medial facet would show you much, I thought, much more accurately the severity of the deformity. So you would look to, for example, this patient, this is the same patient, and if you look to the posterior facet, there's some asymmetry there, but you can really grade a lot of subluxation. And when you look to the medial facet, it's probably more than 50% subluxed. And it makes sense if we think that the subtalar joint axis of rotation is lateral. It's close to the lateral process of the talus. Any rotational deformity because of the lever arm, you're going to see much better in the medial aspect than in the lateral aspect, because the lateral aspect is the center of the rotation, and the posterior facet is more laterally positioned when compared to the medial facet. So just a zoom, and I'm going to speed up here because there will be no time to show everything. But we did a case control study, flat foot patients and controls. We ended up including 30 patients with flat foot and 30 controls. And we did it exactly how it is described in the literature for the posterior facet. So you go to the sagittal, you find the midpoint, you measure the midpoint, and then you put your cut exactly in that position, and then you do the measurements. And we did 2 measurements. We did the percentage of uncoverage and the angulation, or the incongruence angle. That's the way we described it. We find pretty high intra and inter-observer reliability, and if you look here, it's pretty interesting. If you look to the controls, the images, and the flat foot deformity patients, it's pretty severe. And when we look to the numbers, the flat foot patients would have average of 45% subluxation uncoverage, and controls about 5%, and the angulation 17 in the flat foot patients, and almost 0 in the controls. So, and when we did a rock curve for that, we found that very strong numbers for both the percentage of uncoverage and the incongruence. And we found that in this population, if you have an incongruence angle of more than 8.4 degrees, that would be 100% specific and 100% sensitivity for flat foot deformity. So we think that we need to pay attention to the details, and the medial facet was completely forgotten in the literature, and it might be, in my opinion, strong and initial predictor of patients that might have progressive collapse. So we should definitely pay attention to those details, and maybe we can get to the magical numbers. This was from the famous series of the TV. And just would like to thank my mentors at HSS and my friends at the Weight Bearing Society. Thank you so much.
The next speaker is Dr. Burssens from Belgium, and he will speak about some hidden aspect of the medializing calcaneal osteotomy. So we're doing that every day in our practice, and Arne will tell us how we should probably do it better. Thank you, Arne. Thank you.
Good morning, everyone, and also from my side, thank you very much for joining this early morning session. In this presentation, I would like to share with you our results and experience we have using a weight-bearing CT to assess medial sliding osteotomies in flat foot deformities. Relevant disclosures can be found on the AAOS website. And as an introduction, I think we can state that medial calcaneus osteotomies were already described a couple of times ago in 1893 by Gleich, and they were later on reintroduced by Contagidianus in the well-known GPGS papers. Later on, Meyerson advocated the use of the FDL transfer when necessary and reported a good clinical and as well as radiographic outcome. So in conclusion, I think we can state that we have a pretty straightforward procedure. We just have to slide the heel bone 1 centimeter medial, and we already have good clinical results. So why should we even bother and perform further investigations? Especially when we already have these very nice clinical reports by Professor Ellis and Professor Deland at HSS, where it is clearly shown that there's a linear relation between the amount of translation and your obtained hindfoot correction. In addition, they reported that you need to have a postoperative slide varus to have a good patient-reported outcome. And I think these 2 studies already give you a lot of help in your preoperative planning. So what else is there to know? I think firstly, we need to understand that we're performing more than a medial sliding osteotomy. As you can see here in this classical image that is mostly so, you perform a solitary medial translation. But in reality, your heel bone is not positioned straight, it's of course positioned in valgus. And for this reason, you will obtain a slight plantar translation, as well as perform a lengthening of your heel bone towards your foot. And this, of course, are relevant data to know in patients when correcting a flat foot deformity. In addition, it's shown more than to be just a correction of your heel bone. It also has shown to shift the pressure on your ankle joint, as well as reduce the strain on your ligaments and influence, in some sense, the midfoot alignment. But of course, these are all complex factors to assess, and for this, I think plain radiographs have some shortcomings, and I think, therefore, the weight-bearing CT really comes in hand. And when we're talking about flat foot deformities and weight-bearing CT, we cannot go across the paper of Dr. Netto and GBGS, where clearly showed the importance of assessing the weight-bearing on a flat foot deformity. We used the weight-bearing CT in a cohort of consecutive patients, 18 in total, that underwent a medial sliding osteotomy, where we assessed both the hindfoot alignment postoperatively as well as the midfoot alignment. But when we're performing these measurements, we were realizing, when we used the same groups as were performed previously in 2D radiographs and brought them to the CT, that we were actually not using the weight-bearing CT to the fullest. We were not using the 3D information that the CT was providing us, and therefore we tried to translate those 2D measurements to a 3D environment and a 3D setting. And for this, we needed to segment our CT slices, as you can see here, to obtain 3D volumes. And from these 3D volumes, we compute the same angles that were previously used as the hindfoot angle, Miari angle, for your midfoot alignment. Important to know is that you always have to reference these angles towards a coordinate system. There are many described in the literature, but it's important to do so because then you can compare your results in a specific frame and also compare it to those that were found previously. The first thing we assessed was, of course, if this medial translation also concurred with our hindfoot correction, and we obtained also this linear relation where you could see that the amount of translation was related to your hindfoot correction, and with this formula we could compute further on how we needed and how much we needed to translate. The same we did for the midfoot measurements, and this we could see significant improvements, for example, in the navicular height, as well as navicular rotation and or Miari angle, but this was a bit more complex and we didn't find clear linear relationships. But I think both of them clearly illustrate the importance of the translation during your osteotomy. So therefore we further investigated this translation, which factors are influencing this translation, and the first one was our preoperative hindfoot alignment. Because as you can see here, in this case, on the left, we have a slight valgus alignment. But on this case here, we have a more severe valgus alignment of our flat foot deformity. And in each case, if you perform your calcaneal osteotomy, each time 90 degrees perpendicular to the lateral wall, you will obtain here a higher medial translation with a lower plantar displacement. But in the higher valgus deformity, you will obtain a higher plantar translation towards your medial translation. This was also shown in this cohort if we did a correlation analysis, that this preoperative alignment definitely influenced the way you're pushing the heel bone downwards compared to a slight valgus alignment. Next, we assessed what if we would have patients that had another osteotomy angle, would this displacement be different? For example, here is the same severe hindfoot valgus case, where we performed, for example, here the hindfoot calcaneus osteotomy perpendicular to the lateral wall, and here we change this towards a higher angle, and then you see again that your medial translation gets favored. But of course we can discuss a lot of this in tables and translation, but it's still early morning. I think it's good to put this into practice with a clinical case. And this case is a 25-year-old male patient that presented our clinic with a flat foot deformity. His clinical pains were the typical symptoms of mechanical medial foot pain, but in addition to that, he had severe symptoms of fasciitis plantaris, and that, of course, hindered him in his sports and his profession. During clinical examination, we found intact tibial posterior still, but a lot of tenderness on the deltoid, as well as on the T posterior. And we had also a flexible correction of our deformity. These were his plane radiographs that get generated on your weight-bearing CT. So if you like to have a quick assessment in clinical practice, you can use these ones. We translated them towards the 3D volumes. We measured the hindfoot angle in 3D and used the formula. So we know in this case we need to translate around 12 millimeters. And then interestingly, in this patient who has a lot of fasciitis plantaris, you definitely don't want to lengthen the heel bone because his symptoms will aggravate. And so we looked at this heel bone classically. If we would go 90 degrees perpendicular to the lower wall, we would definitely lengthen his heel bone. But for this patient, we calculated which angle needed to be to have a completely isometric translation of your heel bone without ever stretching your fascia plantaris anymore. And of course, then the comment is, how will you obtain this during your surgery? How will you achieve this 97 degrees angle towards your heel bone? Then of course you can print this specific guides on the aspect of your heel bone, and with this your sole bait has directly the right position and the direct angle, so it actually also can save you some time. So in conclusion, I think, and I hope I showed you that the medial sliding osteotomy is more than just performing a medial translation, and I think the weight-bearing CT really improves our understanding not only of the flat foot deformity, but also on your postoperative assessment after your calcaneal osteotomy, and it also shows that it's not only influencing your hindfoot alignment, but actually your entire foot should be assessed, also your midfoot alignment. I hope in the future that we can use these guides to standardize the procedures, and future research should of course assess this in larger patient cohorts, because this was a small cohort and it has concomitant procedures that also could influence your midfoot alignment. But I think the ideas are somewhat there, and of course larger cohorts will answer these questions and hopefully lead us in what is the optimal osteoplane to have a good patient clinical outcome. Thank you very much for your attention.
Thank you very much. I want to invite all speakers to come here to have a discussion. And you can also assess who is the best looking after Arne. So I think we start with a sequence of the talks at the beginning, and then we can also have questions for all speakers together. So who has questions for the first talk? Alexej? Otherwise, I will start. I took some notes here. So, what was my first question? You showed nicely that if you have an external rotation stress, that you can widen the clear space. Mm-hmm. I would suspect here that only the anterior syndesmotic ligament is maybe injured or not stable. And I call into question the clinical relevance, because in Germany especially we have what you probably have in all other countries, a little bit of a sprain. Everybody goes to MRI. Some people see then in the MRI disturbance in the anterior syndesmotic ligament, and they right away go to surgery. In my understanding, this is not a real syndesmotic instability that needs surgery. So what is the clinical relevance of this 10 Newton meter of stress? Is it really relevant as an injury? Maybe not in an ankle fracture, but without a fracture.
Okay. We are not speaking about 10 Newton meters at the time of the injury. We speak about the diagnosis. And the problem is, oh yeah, I can use the microphone, sorry, yes. So quite often, at least once a month, I have a patient, or Dr. Salzman has a patient in the clinic who sprained the ankle in the past, had some lateral diffuse ankle pain, underwent the MRI. MRI showed intact lateral ligament, but some attenuation of the ligaments. They underwent the lateral ligament repair, including quite expensive internal brace fixation. And guess what happened the year after the surgery? Patient has exactly the same problem. So I agree that if you have a complete injury, you don't really need any off rotation. And actually, we also did a second cadaver study showing not just the incomplete, but also we simulated complete syndesmotic instability. And indeed, The torque does not improve if you have an injury of the posterior ligament. But if you have the injury of the posterior ligament, then usually you can clearly see the dehiscence or deviation on weight-bearing x-rays. If you just have a subtle syndesmotic instability with the injury of the anterior ligament, those are the patients which are quite often overseen or actually get treated for lateral instability, which is not appropriate. And the problem is to detect this AITFL injury, which is really hard to do because even sometimes MRI just shows some unspecific scar tissue. I think it's important to apply the external torque. And actually, we created a platform, also radiolucent platform, where the patients can stand and we can measure the torque, and we ask the patients to rotate. And the advantage of the weight-bearing CT, they can keep it just for 20 seconds. That's about 20, 25 seconds where you need to finish the talk, that function. And we just started this prospective study. I hope it answers your question.
Okay, thanks a lot for clarifying. Another question for Dr. Barg. I think I have another question here. So in the latest, not everybody would have this, this talk platform. In the latest Foot and Ankle International, there was a publication. They had an oblique, it was about flatfoot. They had an oblique surface integrated in the weight-bearing CT device, which looks a little bit easier. Would you think that something like a valgus or varus stress, maybe a varus stress, would also do the same because it's easier to apply than to have a... Yeah.
That's a great point, and it may do the same job. However, here I would be a little bit careful as the patient, if he has also a concomitant ankle instability, then we may probably detect the ankle instability will go more in the foreground. So I would say that's for sure easier to use just inclination. Every clinic has it. However, we created this frame or this special platform within a day. And I think we spent less than $1,000, which is still amount of money, but because we were probably too lazy to create it by ourselves, so we requested just to get this done. But I would say this platform, where it's the equal, and you can just apply the external torque, address more specifically syndesmotic rather than the hindfoot instability, including lateral instability.
Okay, very good. So I can tell you what, we will not end this session if we have not at least one question from the audience. But you are still tired, so we will move on now to the next talk. Dr. Wagner, I have also one question, or do you have a question? Yes, here we go. I will repeat it for the recording.
Okay. In your practice, do you do scarf osteotomy?
What is it?
If I do scarf.
The question was if you do scarf osteotomy.
So I'm a believer, you know that, in metatarsal pronation. So if we measure pronation and we see that it's normal, that's below 10 degrees, we would use the intermetatarsal angle, and we do chevrons and scarves if there's no rotation. If there is a rotation and it is healthy and there's no arthritic changes at the TMT joint, we do the proximal rotation osteotomy, which we call the PROMO. And if we see arthritis at the TMT joint, we do a lapidus, also derotating the metatarsal bone. So I agree with you. I don't ever now, I don't ever do a scarf again if I see rotation.
But you think you can have a moderate case without pronation?
Yes. Yes, if you see an article about Yamaguchi, I think, he showed 4 different situations. You can have subluxation of the metatarsal sesamoids without rotation of the metatarsal bone rotated, with sesamoids rotated, not subluxated, and steps in between. So there are 4 different variations. So I guess, yes, the answer is yes.
I have another question. In my understanding, so I have used the weight-bearing CT for more than 5 years now, also for the forefoot. I see the rotation, the pronation in less than 10%. But my question is, if you see it, where is the pronation? In my understanding, it's not within the bone, so it's not flexed, but the entire bone. And if the entire bone is pronated, it's also pronated in the first TMT joint. So if you correct it distally, it could also be done with a modified chevron. You can even rotate with a scarf. You can for sure rotate with a proximal osteotomy. But then you rotate only the distal part and not the proximal part. What about the first TMT joint? Have you seen in the mid or long-term follow-up a problem in this joint, maybe an osteoarthritis or an ongoing instability or even recurrent rotation?
Nobody knows where the medial column instability comes from, and we are indeed involved in a study which we are trying to investigate if it starts at the naviculo-cuneiform joint or at just the TMT joint, and maybe there are some intercuneiform instability which is also providing or creating this rotation. So I cannot agree more with you because we don't know. We don't know where the metatarsal starts pronating, but it's not the bone that is deformed, as you say, it's a joint problem. So as we are correcting an hallux valgus deformity, we are using the bone to correct a deformity which comes more proximal. So that's why you could correct it anywhere along the line of the instability. If you do it too distal, it's harder for the configuration of the bone and you have less potential correction of the varus. So you can choose a point and it will get a little more difficult, the fixation, or more difficult, the correction. But there's no real answer. Where to correct it could be at the joint with a lapidus.
Please.
A great paper. What's the normal rotation? Like, what are we actually aiming for? And sort of just trying to sort out when we actually do our hallux valgus procedure. What's the normal? Like, do we need to get the sesamoids absolutely straight underneath the vertical axis of the leg, or is that overcorrection?
Can you repeat the question for the recording?
So he's asking which is the correct or normal rotation of the metatarsal bone, if it is when we have the sesamoids just lying below the metatarsal head. So the answer comes from radiological studies, not from weight-bearing CT studies, and it goes in between -5 and 10 degrees. So it could be supinated, or it could be pronated up to 10 degrees. And if you choose the population of hallux valgus patients, 87% of that population has a rotation which goes from 10 degrees up. But this, again, I insist, comes from two-plane X-ray studies, and there's one study which used a simulated weight-bearing CT scan, which was not a real weight-bearing CT scan, which is the one we have now. So between -5 and 10 is the answer.
Okay, I'm actually responsible for questions for the last two talkers, but I have just one little questions to you, Emilio, because I think it's an extremely important talk. We all learned how to correct the hallux valgus deformity distally. We know how to do chevron, scarf, etc. Last year, we actually showed that we did a literature review. Initially, we reviewed 3,500 papers, and we saw that up to 25% of all patients with hallux valgus surgery are not happy. And I think rotation is a big thing, and you contribute a lot to understand better this problem. However, my question is, in some of my patients where I tried to correct fully the rotation, and they had before the surgery some degeneration of the articulation between the first metatarsal and sesamoid, they are not always happy. The pain on the inside of the foot gone, but then they complain about the pain underneath the sesamoids. Did you see any of those problems in your practice?
I've been in the situation you mentioned. I've been doing this for 15 years, but this only last years we've been doing this metatarsal pronation thing. I haven't seen again plantar pain or plantar medial sesamoid pain, which I saw when I was doing scarf many years ago, and I said, I'm going to descend the metatarsal bone to get more grip on the medial side. So I'm going to do a scarf with lifting my hand when I do the cut so that I get a plantar translation of the distal fragment. You know what I'm talking about, right? Absolutely. So I had patients in that scenario with medial overload. If you correct the rotation, I haven't seen metatarsal sesamoid pain due to overload. And I have treated people with arthritis. I don't have a number to be sure to say that if you correct rotation, you have less pain coming from arthritis. I hope so.
Thank you, Emilio. Now we will go to the next speaker. Does anybody has any questions towards the Cesar? Maybe I should do the same tactic like Martinus said. If you don't have any questions to Cesar, nobody will leave here. Go ahead.
So I like what you're showing. My concern, especially sort of to both authors there, is when you do medializing calcaneal osteotomy, you're creating a zigzag deformity. And my concern with your subluxation that you're showing and lateral translation and valgus deviation of the medial facet will actually be aggravated by medializing calcaneal osteotomy. Have you seen that?
So the question is, what happens with the medial facet after medializing calcaneal osteotomy?
Thanks for the question. Yeah, great question. So we started doing comparison of pre-op and post-op CT scans. We don't have official data yet, so we have some observations. So we definitely, with most of the procedures we're doing, we are not able to correct the real deformity in the joints. So you don't correct with calcaneal osteotomy. I don't have, like I said, it's not statistically significant. I don't have statistical significance to give you, but what we are observing is that most of the non-aggressive or non-fusion procedures, so the joint sparing procedures that we have been doing, we're not correcting the deformity where it's similar to the first TMT. So we're not correcting the deformity in the joint. So we're not correcting where the deformity is coming from, but along the same thing that Dr. Wagner just said, maybe we can get out of that situation playing along a different aspect of the line of the deformity. So you're doing it extra-articularly, and patients get better. We know they get better, but maybe that's the reason why some of the patients will collapse further in 10, 15 years, because we're not really bringing it back to the anatomy. And then that's why I think the soft tissue part, the first part of my presentation, I really think that interosseous has a very important part into that. We don't have really good techniques to repair or to reconstruct interosseous. There are some publications about that in the past, but it's something that maybe would play a better role than a simple medializing calcaneal osteotomy.
Yeah, I've been in the same situation as Alastair, doing a calcaneal osteotomy, and the subtalar still is unstable, and it goes into more valgus. So I've been in that same situation, ending up doing a fusion. What have you thought about your study, which I loved, maybe including flat feet, asymptomatic flat feet patients, because I'm a flat feet guy. So I'm curious, maybe it will help you to find that magic number, maybe to see when a flat foot patient becomes symptomatic. So maybe not already pathologic and normal. Maybe you need a asymptomatic flat foot group.
Yes, we thought about that. It's difficult to, like maybe if you advertise and please people with flat foot, non-symptomatic could come to join us for weight-bearing CT, it's doable. I really think it would be important. We did scan an intern and at HSS, and I looked specifically for the medial facet, and there was no subluxation. So again, this is just my observation. The study would show that if, I'm pretty sure the number would be a little bit different from the controls, and we didn't, another thing that we could do is the control patients, we have the numbers for example, the foot and ankle offset, so we can tell if that patient has an increased valgus alignment, so we could do different stages of biomechanical alignment to say that, well, let's say if you have an increased foot and ankle offset, or you have so interior, you have more valgus alignment of the hindfoot, so you could do staging that, like for example 5 to 10, 0 to 5, and then you would look to those markers of bone collapse, including the medial facet and sinus tarsus impingement and subfibular impingement. That would be also like a great idea.
I can participate.
Okay, great. We have the first one.
Thank you, Cesar. So does anybody has a questions towards Dr. Burssens regarding his medializing calcaneal osteotomy? I have a questions to Arne. Don't worry, it's not difficult. When I started my residency, it's already a couple of years ago, I'm getting older, which I learned when you do medializing osteotomy, cut the heel, just somehow cut the heel, shift it over 1 centimeter, should be good. Now we learned today, we cannot just cut somehow the heel, we cannot shift we cannot choose like random number. I have 2 questions for you. The first of one, do you still think we need kind of overcorrect, or should we try really to get the perfect neutral alignment? This is the first question. And the second question is, the calcaneal quite often shows different shape, and how we should address the different curvature of the heel. So sometimes I have a feeling the patient has, the contact point is quite medial, but at the same time, the patient has a strong various curvature of the calcaneus itself. So how we should address 2 issues, how we should correct and whether we should ignore or not the shape of the calcaneus.
Thank you very much. There are indeed very relevant questions. I think we should strive towards this neutral alignment. This was been shown, I think, in one of the first papers of the Professor Alice, where we show that there's a slight varus overcorrection is associated with better clinical outcomes. But of course, if you're aiming for a 0 alignment towards the tibia, as was shown here in the studies, this somehow concurs with the slight varus alignment, because if you're going to a straight line in your tibia and your tibia is in a 3 degrees of varus towards your vertical, you also obtain this 3 degrees of varus. So this is what we use currently, but of course this is not really validated, but I think it can be an easy reference to obtain. But also there are other factors constricting during your sliding, that the soft tissue are sometimes restricted, so it's not always that you can do what you have computed before, but I think it could be a good reference. And for the second questions, we didn't have the opportunity yet to look at the shape of the calcaneus, but I think it's a quite good remark, especially the opposite in a lateral sliding osteotomy, where you have the varus shaped heel bones. I think they are even more important than the ones in patients of valgus deformities. But I think it's indeed a good point to have a look at that and see in what sense this shape of the heel bone influences your correction and, of course, your clinical outcome. I hope this answered the questions. Thank you.
Thank you, Arne.
So, a quick question, maybe I missed it when I was hearing your presentation. You investigated the medial lateral angle of your osteotomy. What about the, let's say, coronal angulation of your osteotomy? Because if you change it, you can make a more vertical or a more horizontal osteotomy. So I guess, I think this is not proven, maybe in a flat feet case, maybe I would like to leave the hindfoot a little higher, and maybe that creates more tension in the ligaments, and maybe that helps for the hindfoot instability, for the subtalar instability, I don't know. So did you, maybe I missed it, did you take into account the other angulation of the osteotomy?
This is certainly a good remark. We have published on this angles in foot and ankle surgery, where we describe the 3 of them. So you have your axial angle, your coronal angle, and your sagittal angle. And for the correction, we saw that your coronal and your axial angle were the most important to obtain a good correction of your valgus deformity. But of course, if you change one to another, that changes the whole orientation of your osteotomy. But we try to keep always the sagittal at 45 degrees towards your horizontal plane, and to keep that one stable, and then the other one also, so that we only change one angle at a time if we do this kind of compute. But it's of course a good remark, and we don't know perfectly how this different angles really relate to the correction of your hindfoot and your midfoot. So because they really are closely related to each other, it's difficult to separately assess it, but I think it's important to be aware of them, that you really are doing a 3-dimensional correction. And I think we hope to raise some more awareness with this data. Thank you.
Okay, thank you all very much. It's now the time to come to closing remarks. And Dr. Richter and me, we prepared a couple of slides. And first of all, of course, I would like to thank you all for being here that early morning. Yes, we can show. And of course, special thanks from my side goes to our president, Dr. Richter, then of course Dr. Linz, then of course Dr. Cesar, Netto, and of course Dr. Burssens. And I have to tell, this is a truly study group. So we are a group, we communicate daily, we discuss daily, we collaborate daily, and I look forward for much more many years. Okay, I don't know how often you saw already this slide this year, last year, you will see this also following years. I have to tell, I think, right now in my practice, as much as I can use computed weight-bearing CT, I go for it instead of CT. And yesterday, Dr. Richter shared his manuscript with us, and I could not believe my eyes. I recently reviewed the weight-bearing CT experience at the University of Utah, and we have 1,200 scans. How proud I was. Guess what I get yesterday in the email from Dr. Richter? Over 11,000 scans. Now I can say is at the University of Utah we are beginners. So that's a growing use. We also showed, discussed the publications, and actually one of the very first publications on weight-bearing CT, it was the simulated weight-bearing CT, was the study showing by Dr. Cesar Netto. And this is the study by St. George's and JBJ's in 1999. In the meantime, we have over 70 publications in PubMed. You can see the last one came, the senior author or corresponding author is Dr. Linz. So there is a growing number of the publication, and I bet when we met at the next academy, this will be over 100. We continue strong research, and again, Dr. Richter has invaluable treasure now of 11,000 scans he can review. We know that Dr. Linz has an incredible number of research going how we should analyze the x-rays. And I know that the Cesar, the Netto, he's becoming a clear expert in the flat foot deformity. And every time I see him, I learn something. I knew already before that the spring ligament is a problem in the flat foot deformity, but now I know that's also interosseous ligament is probably one of the key players. At the University of Utah, we have a research fellowship, and Dr. Cranbull, I showed the results of his study. He spent a year, then Dr. Burssens was there. Right now, Dr. Sripanic is working with us, and he's actually working on using weight-bearing CT to assess the least frank instability. So we have a growing number of members in our society. This is the homepage, and keep in mind, all the meetings are recorded, and actually the videos will be announced at the page. At last but not least, I would like also to mention that the study group, the board of the study group is working right now on the book, and we will summarize what has been done regarding weight-bearing CT. We will also summarize, okay, what will be done in the future, and we will share in this book the results of our research. And I have to tell, the book will be written not just by 5 of us. Everybody who contributes to this field will be part of this book. At this point, Dr. Richter, Dr. Burssens, Dr. Cesar, Netto, Dr. Linz, but also me, we would like to thank you all for coming here that early morning. And I absolutely look forward, we all look forward to see you and to discuss with you in the future. Thank you very much. Thank you.